Actually, I'm the pediatrician, and then I don't know that I can spend that much information in terms of adult transplant because both of you are adult hematologists. So I'm going to talk probably around 80% of my time going to be in pediatric, and then what we can learn from the pediatric in terms of transplantation, and then a little bit in terms of transplant upfront in adult in adult ALL, especially the first CR for the transplant. So in terms of pediatric, you can see that from Pui, this is from St. Jude Children's Research Hospital, and I published several years ago. And then you can see that right now in terms of childhood ALL, we can achieve in terms of thalassemia-free survival almost around 90% at this time. So what we can learn from the pediatric ALL. And then when I get back from St. Jude, because at that time I got training from St. Jude, and then right now it's 16 years already. So I try to develop the protocol in my hospital, and then to see that we can achieve the same outcome or not. So we developed the protocol 13 at the first, when I get back to Ramatipudi, like the first 6 years, and then after that, another 8 years, total 15. Actually, we can have the same outcome like in the North America. So basically, if we have some kind of good intensive, good supportive care in terms of what we call developing country, we can achieve the same outcome as North America. And so you can see that when we would like to try to treat the pediatric ALL, we subcategory and in terms of divide this patient in terms of pediatric ALL as a genotype by in terms of genetic translocation. Here in Thailand, at the beginning, we tried to develop multiplex in terms of RT-PCR, and then we, based on the multiplex RT-PCR, in terms of categorize pediatric ALL. As you can see that this is by only the chemotherapy. You can see that this group of the patient can achieve the long-term good survival, but in terms of two groups like infant ALL, in terms you can achieve, and then the other one is Philadelphia chromosome ALL. And then this is a bad outcome in terms of this group, these two group of patients. And the high-risk ALL in terms of pediatric, we categorically like a slow early response, like the blast count on day 8, and then bone marrow assessed in terms of various time points, and then especially we try to develop in terms of metabolizal disease. Once we see some kind of MRDs got positive, so we can give more intensification of the chemotherapy. So this is the way how we do. And then in terms of this, we call it induct, and then the other one, induction failure, like at the end of induction, more than 5% of blast. This is we call the high-risk ALL, infant ALL and the Philadelphia chromosome. And the other group we call hypodiploid and high-risk T cells ALL. All of this group we call the high-risk childhood ALL, and then probably this group we may be considered in terms of bone marrow transplantation whenever the donor is available. And from the hematopoietic stem cell transplant for the pediatric ALL from the ASBMT expert panel consensus in pediatric. And then you see that the first CR we perform right now in terms of benefit of the transplantation is only the Philadelphia chromosome positive. But the rest of that, as I mentioned to you, that's a clinical trial in terms of evidence base for the transplant in the pediatric ALL. So right now the transplant probably just only the Ph ALL positive. This is for the consensus, but the rest of the clinical trial. However, in our institution, in terms of transplantation, we perform in terms of the one who's available, donor available, in terms of Ph positive ALL, or end of induction, we got blast more than 5%, and then infant ALL we perform in terms of transplantation, and this is only 3 categories that in our institution perform the transplantation. Like 5% blast at the end, MLL and the Philadelphia chromosome positive. And right now, I'm just move on in terms of pediatric Ph positive ALL. This is from the North America in terms of 267 patients, Philadelphia ALL, compared between the chemotherapy and the transplantation. And then you can see that this is a 2-arm between chemotherapy only and the transplantation. You can see that we can achieve a very good outcome in terms of transplantation in case of the Philadelphia chromosome positive. However, all the Philadelphia chromosome positive ALL in pediatric, it's not all the patients need a transplantation. Basically, the one who has a best, in terms of best prognosis, like the age less than 10 or white count at the beginning less than 15,000, probably this patient, this is a chemotherapy only. You can see that probably this group of patients, we can avoid the bone marrow transplantation in terms of group, the best prognosis of pediatric Ph positive ALL, like an age less than 10 and a white count less than 50,000. So in our institute right now, so we consider the transplant whenever the Philadelphia chromosome in terms of white cell more than 100,000 patients. And then this is, as you can see that this is Arico published in the 2000, and then Arico, he confirmed the data again in terms of in the JCO that and then the transplant can achieve the better outcome than the chemotherapy only in terms of compare between transplantation and then chemotherapy in the pediatric ALL. And then you can see that whatever, no matter what the transplant with related or unrelated and have a good outcome, especially in this data from the pediatric ALL, actually the unrelated can achieve the better outcome than the related, probably more in terms of graft versus leukemia effect in terms of using the unrelated donor. And this is improved outcome unrelated 5 year, this is 41 versus in the 58. I mean the 41, this is the unrelated in terms of 2000, and then it can achieve to the 55 in the next cohort of the patient. So it means that unrelated may be considered at the beginning in terms of pediatric Ph positive ALL, especially the worst prognosis like the white count more than 100,000 Philadelphia chromosome positive. This is another data from the North America, Kirk Schultz. He published the data in JCO, and he tried to avoid the transplantation in Philadelphia chromosome positive. This is a schematic of treatment of very high risk of ALL, and then Philadelphia chromosome is consistent. It's incorporated in this in this study, and you can see what he did in terms of this is event-free survival in terms of before the anecdotal data compared between the transplant and then chemotherapy only. But in terms of this group, and then they tried not to give, not to do this group of patients, just give the Imatinib to the patient whenever after the end of induction, and then this group of patients give the Imatinib along the chemotherapy for the 3 years of the chemotherapy in this group of patients, and then compare between the transplantation, related and unrelated. And then from this cohort, it seemed that right now in terms of Philadelphia chromosome positive ALL in a group of patients, probably we might not need a transplant at this paper, because you can see that if we give the Imatinib along with the chemotherapy for the pediatric Ph positive ALL, it can achieve the outcome the same as a related or unrelated of bone marrow transplantation. However, this study is some kind of the small number of the data. You can see that the chemotherapy plus Imatinib is only 25, and then related and unrelated is only 20 and 11. So right now in terms of North America, they try to some kind of get all over the worldwide in terms of Europe, Asian, and North America, and try to convince that we can get away from the transplant or not in terms of Philadelphia positive ALL in terms of pediatric patient by using the chemotherapy, like 3 years of chemotherapy and plus Imatinib. And then we have to see probably in next 2 or 3 years the result of this. So what about the infant ALL? As you can see that I showed you the slide already, the infant ALL with only the chemotherapy only, you can achieve the survival is only around the 20%. And then infant ALL, no matter what use the chemotherapy, this is a very bad outcome. But however, in terms of infant ALL, like age less than 1 year of age, it's not a single disease. They have some kind of infant ALL you can divide in terms of 3 groups. Like the group 1 is a germline in terms of MLL gene, and group 2 is like ML gene rearrangement and is less than 6 months, and white count more than 300,000, and group 3 is all other patients. And then you can see that in this group of patients, infant ALL, by using the chemotherapy only, and the best outcome is a group that is the group that is a germline ML rearrangement. However, the bad outcome is the one that ML rearrangement at the age less than 6 months of age, as the white count more than 300,000. So it's been that in terms of infant ALL patient, it's not like all the patients we need the bone marrow transplantation. Probably in terms of group of patients got the germline ML, even though it's less than 1 year of age, we can give the chemotherapy and get the best outcome like this. So this is hematopoietic stem cell infant ML from this group of patients. So in this paper, they some kind of try to do the bone marrow transplant upfront in terms of infant ALL, and then including the low risk and high risk of patient, and then this group of patients, and then in terms of 37 of infant ALL, this group of patients performed the bone marrow transplant, and with the various donor like a matched sibling, unrelated, mismatch or whatsoever. And you can see that compare between the chemotherapy and the transplantation. This is the arm of hematopoietic stem cell transplantation. It seems like the hematopoietic stem cell transplantation have a better outcome than the chemotherapy only, something like that. However, once it breaks through already, and you can see that this is a group of the chemotherapy, and then this group of patients, and then this is the transplantation. Compare between two groups, and this one is in terms of the good risk of the chemotherapy, the good risk of infant ALL. You can see that the chemotherapy and then the transplantation has the same survival. It means that this group of infant ALL has a MLL germline. However, in the group of the patient of the infant leukemia has a MLL rearrangement, this group of patients have a better outcome with the hematopoietic stem cell transplantation. So from this paper, it seems like we recommend that infant ALL with the MLL rearrangement, we need to do the bone marrow transplantation to get the better outcome other than do the chemotherapy, which had the worst outcome in the group of infant with MLL rearrangement. What about the T-cell ALL? This is a high-risk group of T-cell ALL from the BFM 90 and BFM 95, and you can see that compare between the stem cell transplantation and the chemotherapy. And then the T-cell ALL high risk is been that the poor response at the 7 days with the prednisolone, and then the failure to achieve remission. I mean, at the end of induction, if have a blast more than 5%. In this group, we call the high-risk T-cell ALL, and then compare between the stem cell transplant and chemotherapy. And then you can see that the stem cell transplant has a better outcome than the chemotherapy in terms of high-risk group of T-cell ALL. And no matter what, using matched unrelated donor or matched sibling has the same outcome, in terms of good outcome. And then subcategory of a T-cell ALL, especially this is they put it together in terms of data from St. Jude and data from the Italian group. And you can see that if the T-cell ALL had the early T-cell precursor marker, and you can see that this is early T-cell marker, and this is another T-cell ALL, and you can see that both institutions can achieve the better outcome in terms of T-cell. In terms of T-cell, that's not the early T-cell precursor. So it means that if the patient got the T-cell ALL and the marker that show the early T-cell precursor, this group of patients probably we need the bone marrow transplantation. So this is another marker for the T-cell ALL. When the patient have a T-cell ALL with the early T-cell precursor, this is a bad outcome. So that's why we need the bone marrow transplantation in this group of patients. And then in summary, in terms of pediatric ALL, right now the CCG, they try to do, we call the ultra high risk, and then this group of patients, probably we might need the bone marrow transplantation. As I said, that in terms of cytogenetic 922, this is a must to do perform the bone marrow transplantation, especially in terms of 922 that has a white count more than 100,000. And the rest of that, in terms of EOG, that recommend is a 411, like 11q23 rearrangement, like infant leukemia or hypodiploid. And then the T-cell ALL with the high white count, like 100, more than 100,000, especially the early T-cell precursor. Induction failure, like at the end of induction, got the blast count more than 5%. So this group of the patient, the COG right now recommend to do the bone marrow transplantation. So what kind of regimen for the bone marrow transplant in this group of patient? And then still recommend the Cytoxan and TBI. So, and then, so the regimen that's what I'm going to tell you, that in terms of children ALL, so the TBI is still remain the best option for the bone marrow transplant in children. Like in this group, in this paper, the TBI and cyclophosphamide had a better outcome compared between the both sides. And then this is another one paper, and you can see that in terms of TBI, the best conditioning regimen had a better outcome than the chemotherapy alone. So in summary, the indication for the hematopoietic stem cell transplant childhood, a very high risk group like a Philadelphia chromosome positive, like a white count more than 100,000, and then the T cell white count more, like a bad, I mean in the high risk group of T cell, especially like early T cell precursor, and the end of the induction, blast more than 5%. And the preparative regimen in terms of pediatric, we still use the TBI containing regimen because this has a better outcome in terms of leukemic-free survival or something. What about the adult acute lymphoblastic leukemia? I'm not going to pay attention that much because the two speakers has been talking about a lot about this. So it means that the adult and pediatric in terms of risk group, in terms of standard, or the poor risk group, basically in terms of cytogenetic, everything pretty much the same, just only different in terms of age. Like in terms of adult, the age less than 35, they call the standard risk group. In terms of poor risk group, the age above than 60 years old. And the rest of that group pretty much the same, like a white count, phenotype, or the genotype, BCR-ABL, or minimal residual disease, pretty much use the same. The reason why, because the adult program they try to develop in terms of strategy from the pediatric ALL patients. So this is a high-risk feature in summary, as is the same, that's what in terms of B cell, age above than 35, we call the high risk, and then high white count, everything is the same in terms of nitrogen to translocation, MRD, and BCR-ABL. And then the difference between an adult and pediatric, because adult have a more bad cytogenetic, especially in terms of BCR-ABL, compared to pediatric. BCR-ABL is only around less than 5%, but in terms of adult, in terms of Philadelphia chromosome, is almost 25%. However, in terms of good risk, and then you can see that it's occur common in children, like a hyperdiploid, it's around 20 to 25 in children, and then tail AML, it's occur common. This is a good risk for the cytogenetic. It's occur quite common in terms of children ALL. So that's why probably the children ALL has a better outcome than adult, because has a more good cytogenetic in children population. So you can see that this is from the different chemotherapy that they try to use, like in French and from MD Anderson, from the other protocol, and you can see that the 5-year disease-free survival, it's only around somewhat around 30% all over the world. And then this one, compared to the pediatric, it's almost to 80 to 90% like this. So that's why probably adult maybe might need in terms of transplantation to get the better survival. The role of hematopoietic in adult, like I said, this is from the French protocol study, and you can see that the ASBMT, especially the high risk, has a significant in terms of got the better outcome like this. This is ASBMT, the high risk, compared between the ortho and the chemotherapy. And you can see that this is data, there's data confirm that the high risk group has a better outcome when the patient underwent the allogeneic stem cell transplantation, and the p-value like a 0.009 from this paper. And then from the several data that in terms of allo hematopoietic in high risk ALL, from several data, it can have achieved the long-term survival around the 40 to 60%. So it means that the high-risk ALL patient in adult probably get a better outcome with the allo transplantation. What about...
Dr. Hongeng, sorry, at the front. We're running well over time, so maybe we could stop there and maybe we could ask for some questions.
Yes. So this is the last slide because I'm going to pay attention that much. Because probably in terms of the 5 risk group for the transplant, probably the minimal residual disease study, pre-transplant management to achieve the below, and the better conditioning regimen by give the low toxic dose as you can, as you said already, better anti-leukemia effect like a cofirabin for the better conditioning regimen, and low the post-transplant as you see already, like to give the TKI, biological agents, and adoptive cellular. This is after transplantation.
Thank you very much. Come and join us at the table. We might just have time for 1 or 2 questions. As you can see, it's not a black and white debate. It's not a yes-no answer in adult ALL, but it is an exciting time to be a hematologist treating ALL, whether it be adult or pediatric, because of many of the options that we have available to us. So, Swami, how long should we plug on with a TKI in combination with chemotherapy before jumping into transplant?
It's a very good question, and you're absolutely right. I think we agree more than we disagree in this disease. I think it's important that the combination of TKI and chemotherapy proceed to the maximum response, which is the minimal residual disease and beyond. And obviously, I think as I said, it's an individual patient decision. If you do find a donor, it's very reasonable, at least in the adults. Yes, you saw the pediatric data where pediatric patients do well with just chemo and a combination of Imatinib. In the adults, it's a little different, and perhaps if you do find the donor, I think my recommendation still would be to proceed with the transplantation. On the other hand, if you don't find a donor, obviously you have to proceed with the maintenance aspect, and as I said, there are anecdotes of several of these patients from these studies, Imatinib, Dasatinib, and we did a case series of Nilotinib, to proceed with just the TKIs and the maintenance for the first 18 months and then subsequently just the TKI. How long to be on the TKI, that's a question. It's 2 years beyond the maintenance or longer. As long as you see a negative transcript, I would just still continue the TKI.
Thank you. And Dr. Hongeng, do you think that adult ALL treating doctors like myself should be tougher on our patients and apply the pediatric protocols, or are we just fighting against biology? Is the adverse biology of adult ALL not worth the pain of trying to apply a pediatric regimen?
I think that not just because of the biological agent that's different from adult, between adult and pediatric, but I think the host in terms of toxicity that adult maybe is not tolerate the high dose of chemotherapy like in pediatric. However, the way how we approach for the pediatric ALL is different in terms of adult and pediatric, because the pediatric patients, we put the patient on protocol continuation of the chemotherapy. It's not like you give the big dose of chemo and then after that, like adult, like a hyper-CVAD or something, because you give the chemotherapy and then you have the period of time to rest to let the bone marrow to recover. But the pediatric ALL, we use some kind of chemotherapy all the time. So probably maybe we just stay on the chemotherapy for almost 3 years. So probably that's why the pediatric ALL has a better outcome in this group of patients. So what I think that maybe age less than 30 years in terms of adult ALL, probably we need to put on the pediatric protocol.
Thank you. Any other points or questions that people have? If not, in the interest of time, I'd like you to thank our 2 speakers. Thanks very much.
Thank you.